Welcome back to the deep dive. If you're listening to this right now, I'm guessing you're surrounded by open textbooks, maybe some highlighter pens, and probably a very cold cup of coffee. You're probably feeling that specific kind of dread that only comes with preparing for the MD anesthesiology exams.
It's a very familiar feeling. The syllabus feels endless, and the time is always short.
Exactly. And today, we're not just, browsing a topic for general interest. We are on a mission. We're treating this hour as a really intensive revision session.
Good.
So I'm stepping into the shoes of the resident, the frantic exam candidate, and you are my senior faculty mentor. I've got Miller's Anesthesia, the 10th edition, of course, open on the desk, along with Morgan and Mikhail and Yao and Artuzio.
Excellent choices. Those are your Bibles for this.
And the topic we're tackling today is one that I think a lot of us, myself included, really underestimate. It's NORA.
NORA.
Non-operating room anesthesia. And my first instinct, and you can be honest, is this a trap, is to think, oh, NORA. That's just giving a little sedation for a CT scan. Easy marks. I'll study that the night before.
And that attitude right there is exactly how you feel, Aviva. It is the classic trap. You walk in thinking it's anesthesia light, and the examiner, well, they destroy you.
Okay.
NORA is deceptively simple, but it is actually a minefield. I mean, it tests your physiology, your pharmacology, your physics, and above all, your crisis management skills in what is, frankly, a hostile environment.
That's what we are here to unpack. We're going to convert this from a soft topic into a high-yield mark-scoring machine. We're going to follow a really strict structure today, covering everything from the definition, the locations, the preparation.
The SOAPME mnemonic.
Exactly. And the specific management of these high-stakes areas like the MRI suite and the Cath lab.
Sounds like a solid plan. Let's get to work.
All right, so Part A, introduction and exam framing. If I get a theory question that just says, NORA, or if an examiner stares me down in the Viva and asks, Doctor, define NORA, I can't just say anesthesia in the basement.
No.
I need the textbook definition.
Precision is absolutely key here. So NORA stands for non-operating room anesthesia. It's defined as the administration of anesthesia services. And this part is crucial, ranging from minimal sedation to monitored anesthesia care, or MD, all the way to general anesthesia.
All right.
In locations physically remote from the main surgical suite.
Okay, so physically remote is the geographic constraint, and the range of services part means it's not just a bit of sedation.
Correct. And to really impress the examiner, you need to contextualize it. You have to mention this is an exploding field. According to Miller's, the demand for NORA is increasing exponentially.
Really?
Oh, yes. In the U.S., for instance, statistics show NORA cases shot up from about 28% to over 36% of all anesthesia procedures in just a few years.
Wow. That's a massive chunk of our workload. It's practically, more than a third of what we do?
It is. We are seeing anesthesiologists in cardiology, in radiology, gastroenterology, pulmonary medicine, even psychiatry. It's no longer a niche. It is completely mainstream practice.
But here's the kicker. You mentioned earlier that this is high risk. Why? Is it just because the lights are dim, or is there more to it?
It's what I call the sick patient paradox. This is a concept you absolutely must mention in your answer. Think about it. Why do we send a patient for, say, a TAVI, a transcatheter aortic valve implantation in the Cath lab, instead of an open valve replacement in the OR?
Well, usually because they're too old or just too sick for a big open surgery.
Exactly. They are ASA 3 or 4. They've got severe heart failure, COPD, maybe renal dysfunction. They are deemed too high risk for the operating room.
Okay.
So we take these incredibly fragile patients who have zero physiological reserve, and we move them to the most remote, least equipped, most unfamiliar room in the hospital.
So the patient is sicker, but the location is worse.
That is the paradox. Minimally invasive surgery does not mean minimally invasive anesthesia. The patient's heart doesn't know it's in the basement. It still requires stability. That is why NORA is so high risk.
That's a really powerful opening for an essay. Now, looking at past exam papers, how does this topic usually show up?
You'll see 3 main patterns. First, the short note. Challenges of anesthesia outside the OR.
Right.
That's a gift if you know your headings.
Right.
Second, the long question or a clinical scenario. Something like, discuss the anesthetic management of a patient with a pacemaker scheduled for an MRI, or management of a morbidly obese patient for ERCP.
And the Viva?
And third, the Viva. The Viva is where they test your safety instincts. Doctor, you're in the CT scanner, the patient stops breathing. What is your immediate action?
Okay, safety instincts. We are definitely going to drill those. So let's move to Part B, locations for anesthesia outside the OT. In Aviva, if I'm asked to list the locations, I want to sound organized. I shouldn't just be, listing them randomly.
No, you shouldn't. Group them by specialty. It shows you have a structured mind. It looks professional.
Okay, so group 1.
Group 1 is radiology. This is the big one. It includes CT scans, MRI, and interventional neuroradiology.
What's that, like coilings?
That's your aneurysm coilings, your stroke thrombectomies. Also, nuclear medicine for peaky scans. That's all under radiology.
Got it. Group 2.
Group 2 is gastroenterology, the endoscopy suite. Think ERCP, EUS, colonoscopies.
Okay.
And Group 3 is cardiology, the Cath lab. That's your coronary stents.
Right.
TVI, MitraClip, and also the electrophysiology, or EP lab, for ablations and pacemakers.
Right. Radiology, GI, cardio. Are there any others I should mention to get full marks?
Yes, absolutely. Mention pulmonary for bronchoscopy suites.
Yeah.
Mention radiation therapy, especially for pediatric patients who just cannot hold still for the treatment.
Oh, of course.
And also psychiatry for ECT, electroconvulsive therapy. And don't forget urology for lithotripsy. If you list all of those, you've pretty much covered the entire map.
And strictly speaking, the relevance of anesthesia in all these places is basically the same, right? Immobility, anxiety relief, and pain control.
Yes, the goals are the same, but the environment in which you provide those things is what can kill you.
Right.
Which brings us perfectly to Part C, the unique challenges in NORA. This is what you'd call the hostile environment section.
Hostile environment. I love that phrasing for an exam. It sounds so dramatic.
Well, it is dramatic because it's true. Millers discusses what it calls the medicine anesthesiology culture gap. In the OR, you are the master of the domain.
Mm-hmm.
The table moves when you say so. The lights are bright. The nurses know what a laryngoscope is. In the OR suite, you are a guest, and often an unwelcome one who's seen as slowing down the turnover.
Okay, let's break down these challenges. What's number 1?
The first challenge is the remote location itself. You are physically isolated. If you have a cardiac arrest in the main OR, you yell, "Help!" And, 10 colleagues run in from the adjacent theaters.
Right, you get a flood of help.
Exactly. If you have an arrest in the basement MRI suite, you are alone. The code team is 5 minutes away. The pharmacy is on the 4th floor. You are completely on an island.
Help is not next door. That's a key line to remember.
It is. The second challenge is limited access to the patient. In the OR, you're at the head of the bed. It's your space.
Sure.
In the cath lab, the C arm is rotating around the head. In the MRI, the patient is inside a 2-meter-long tunnel. You're often pushed to the foot of the bed or behind a lead screen. If the airway obstructs, you can't just reach out and fix it. You have to climb over a mountain of equipment.
And the space itself, I'm guessing it's not designed for us?
Not at all. That's the third challenge. Inadequate space. These rooms are built for scanners, not for anesthesia machines. You're often squeezed into a tiny corner.
Which leads to poor lighting, I imagine.
That's the next one, poor lighting. In fluoroscopy or endoscopy, they dim the lights to see their monitors. You are literally working in a cave. You can't see cyanosis. You can't read the labels on your syringes easily.
That sounds like a perfect setup for a drug error.
It absolutely is. And finally, the fifth challenge is staffing. The nurses in these suites are experts at their specific procedures, but they are often not trained in anesthesia crisis management.
So they might not know where the difficult airway cart is?
Or how to apply cricoid pressure, or even what succinylcholine is for. You are often the only airway expert in that entire room.
Okay, that covers the environmental challenges pretty comprehensively. Now, let's go back to the patient. We talked about the sick patient paradox. Part D, patient-related challenges.
Right. We have three main groups to think about here. First, pediatrics. Now, kids are often healthy, but they need NORA for an MRI or a CT because they just can't lie still.
Right, you can't reason with them.
Exactly. The challenge here is the requirement for absolute immobility in a scary, loud tube. You can't explain it to a 3-year-old. So you're often forced to use deep sedation or even general anesthesia for what is a purely diagnostic procedure.
Which carries its own risks.
Yeah.
And the other end of the spectrum, the elderly.
Geriatrics. These are your high-risk TVI or stroke patients. They have significant comorbidities. Cardiac failure, COPD, renal failure, they have zero reserve. A little bit of hypotension that a 20-year-old would tolerate can cause a devastating stroke or myocardial infarction in these patients.
And then there's the acutely sick patient, the unstable or critically ill.
Yes, the patient with sepsis coming for an ERCP to drain an infected biliary tract, or the patient with a subarachnoid hemorrhage coming for coiling. These patients are physiologically on the absolute edge of a cliff, and we are managing them in the dark, far from home.
Okay, so we've established the environment is hostile and the patients are sick. How do we survive this? Let's get to Part D, pre-anesthetic preparation. This feels like the area where I can really score points for demonstrating safety.
This is where you pass or fail. The golden rule, and you must write this in bold letters in your exam answer. The standard of care in NORA must equal the standard of care in the operating room.
No shortcuts.
No shortcuts, ever.
So the pre-procedure assessment is exactly the same.
Identical. A full history, physical exam, airway assessment, Mallampati score, ASA classification. You need to know their MIT-Ts, their functional capacity.
And
And crucially, fasting status. This is the single biggest point of friction with the proceduralists. The gastroenterologist wants to squeeze in a case. They'll say, oh, he had a light snack 4 hours ago. It's fine.
But it's not fine. What are the guidelines again?
The 2-4-6-8 rule. You need to know this by heart. 2 hours for clear liquids, 4 hours for breast milk, 6 hours for a light meal or formula, and 8 hours for a fatty meal.
And you have to hold the line on that.
You have to stick to that. If a patient is not fasted and it is not a life-saving emergency, you do not sedate them. The risk of aspiration in a remote location where the suction might be inadequate is a career-ending event. You have to be the one to say no.
Okay, that's a key safety point. Now let's talk about setting up the room. I'm walking into a strange room in the basement. I need a checklist. I need a mnemonic.
The mnemonic is SAPME. You might see MS made in some books, but SAPME is the gold standard for exams. If you write this out vertically in your answer book, the examiner immediately knows you are systematic and safe.
Okay, let's walk through it.
S. S is for suction. Why is it first? Because in remote sites, suction is often an afterthought. It might be a portable unit in the corner that isn't even plugged in.
Or the wall suction is weak.
Exactly. You do not want to discover you have no suction when the patient vomits. So you check it first. High pressure, working Yankauer, ready to go.
Okay. O is oxygen.
O is for oxygen. Verify the pipeline pressure. But crucially, and this is a common mistake, verify the backup cylinder. Remote sites are notorious for pipeline failures or pressure drops. You need a full E-cylinder on the back of your machine, and you need to have checked it's full.
Got it. A is airway.
A is for airway. You need the full range ETTs, LMAs, laryngoscopes, but here is the critical exam point. You need a difficult airway cart. If you are in the OR and you can't intubate, you just yell for the video laryngoscope from next door.
But in the basement?
In the basement, you can't wait 10 minutes for someone to run it down. It has to be physically present in or immediately adjacent to the NORA suite.
Okay. P is for pharmacy.
P is for pharmacy. Specifically, emergency drugs, ephedrine, atropine, succinylcholine, adrenaline. They need to be drawn up or immediately accessible, not in a code cart down the hall, on your tray, ready to go. When a patient crashes in a scanner, you have seconds, not minutes.
M is monitors.
M is for monitors. Standard ASA guidelines apply. ECG, NIBP, pulse oximetry. And the big one, which we'll come back to, capnography. It must be there and it must be working.
And finally, E.
E is for equipment. This covers the defibrillator. Is it there? Is it charged? Do the pads fit? And the most important piece of low-tech safety gear you have, the self-inflating ambu bag. Why is this so critical?
Because if the anesthesia machine fails or the wall oxygen cuts out,
Right.
the ambu bag allows you to ventilate with room air. It's the ultimate fail-safe.
Precisely. If you are completely dependent on the machine and the machine dies, you are helpless. The ambu bag is your parachute.
That SOPME list is absolute gold. Okay, moving on to Part E, anesthetic techniques in NORA. We keep saying sedation, but there's a whole spectrum, isn't there?
Right. For the exam, you need to reference the ASA continuum of sedation. You should be able to define each level.
Okay, what's level 1?
Level 1, minimal sedation or anxiolysis. The patient responds normally to verbal commands. Airway and cardiovascular function are completely unaffected.
Level 2.
Level 2, moderate sedation. This is what used to be called conscious sedation. The patient responds purposefully to verbal or light tactile stimulation. The crucial part here is that the airway is patent and spontaneous ventilation is adequate.
And then it gets more serious. Level 3.
Level 3, deep sedation. Here, the patient is not easily aroused. They respond to painful stimulation. This is the danger zone. Why? Because the airway may be compromised and spontaneous ventilation may become inadequate.
And finally, level 4 is just GA.
Level 4, general anesthesia. The patient is unarousable, even to painful stimuli. Airway support is almost always required.
So the real danger for the anesthetist is that slippery slope from moderate to deep, isn't it?
That is the valley of death in NORA. You give a little midazolam, they're fine. You give a little propofol, and suddenly they're snoring, obstructing, and their SATs are dropping.
Which leads to the rescue concept.
Exactly. This is a key safety principle. The guidelines state, a provider administering sedation must be able to rescue the patient from one level deeper than intended.
So if you're aiming for moderate,
If you plan for moderate sedation, you must have the skills and the equipment to manage deep sedation and a complete airway obstruction. If you can't intubate, you shouldn't be pushing propofol in a basement. It's that simple.
that makes total sense. Now, what about the actual technique? Is it TIVA or inhalational? What's the preference?
TIVA, or total intravenous anesthesia, is usually preferred in NORA. And for good reason.
Why is that?
Well, drugs like propofol and remifentanil are the workhorses. They have a rapid onset and, more importantly, a rapid offset. We want our patients clear-headed for a quick recovery and discharge. Also, many remote sites lack proper scavenging systems for anesthetic gases. If you run sevoflurane in a poorly ventilated room, you're essentially polluting the environment for yourself and the staff.
But you're not ruling out GA entirely.
No, absolutely not. Do not rule out general anesthesia. If the patient is uncooperative, if the procedure is long, or if the airway is shared, or if the patient is prone, just intubate. Secure the airway. Millers actually suggest having a low threshold for converting to GA in NORA to ensure safety.
Okay, let's drill down on monitoring now. Part 8. You've mentioned capnography a few times. It sounds like a big deal.
It is absolutely essential. In a dark room, clinical observation is unreliable. You can't see the chest rise clearly. You can't hear breath sounds over the noise of the MRI.
And the pulse oximeter isn't enough.
The pulse oximeter is a lag indicator. This is a crucial point for your exam. If a patient is on supplemental nasal oxygen, their saturation might stay at 100% for several minutes, even if they have completely stopped breathing.
That's apneic oxygenation.
Exactly. By the time the SATs finally drop, you are already deep in a crisis. You've lost valuable time.
Whereas capnography?
Capnography detects apnea breath by breath in real time. It's your early warning system. For the exam, if they ask about monitoring, you must say standard ASA monitors with continuous capnography. It is completely non-negotiable.
Okay, message received. Let's get into the specifics. Part F, procedure-specific considerations. This is where we apply all this theory. Let's start with the one that feels like it's from science fiction, the MRI suite.
Radiology and MRI. The defining feature here is the magnet. It's a huge superconducting magnet. And the most important thing to remember is that it is always on. You cannot turn it off.
And the main hazard is the projectile effect.
It is, the projectile effect. Any ferromagnetic oxygen cylinders, laryngoscopes, scissors, pagers, even your keys will be pulled into the bore of the magnet with lethal force. They become missiles.
So all the preparation is about making sure everything is compatible.
Yes. You need MRI-compatible equipment. Your laryngoscopes must be aluminum or plastic. Your oxygen cylinders must be non-ferrous, so aluminum. The anesthesia machine itself must be specifically designed to be MRI safe. Even the stretchers and IV poles have to be non-ferrous.
And what about the monitoring challenges? The magnet messes with the ECG, right?
It does. The blood flowing through that intense magnetic field actually creates a voltage potential. This mimics the T wave on the ECG. You get something called T-wave swelling, or artifacts that look just like dangerous arrhythmias. You need special filters to interpret it correctly.
And what about burns? I've heard of that.
Yes, burns are a real risk. The ECG cables can act as antennas in the magnetic field. If they're coiled or looped and they touch the patient's skin, they can heat up and cause full-thickness burns. You have to run the cables as straight as possible.
Wow. And airway access. The patient is completely inside a tunnel.
That's the nightmare scenario. You were in the control room or at the patient's feet. Their head is 2 meters away inside a narrow tube. So the key rule is, secure the airway before they go in.
Make sure it's solid.
If you use an LMA or a tube, tape it more securely than you ever have before. Use long circuit extensions. Because if the patient disconnects or rests inside that tunnel, you cannot help them there. You have to undock the table and pull them out immediately.
Which brings up the code blue in an MRI scenario. What's the protocol?
The first rule is, do not take the crash cart into the magnet room. That is an automatic fail in any exam. The defibrillator and the steel oxygen tank on that cart are ferromagnetic bombs waiting to launch.
So what do you do?
The protocol is simple. 1, recognize the arrest. 2, undock the table and move the patient OUT of the magnet room, which is zone 4, to the control area, which is zone 3.
Out of the room first.
Out of the room, close the door, and then you start ACLS.
Got it. Zone 3 is safe. Zone 4 is the magnet. Okay, let's move on to endoscopy and bronchoscopy. What's the main battle here?
The main battle is the shared airway. the gastroenterologist or the pulmonologist is working in the mouth, which is exactly where you want to be to manage the airway.
And ERCP is the classic exam topic, right? Why is that one so tricky?
A few reasons. One, the position. The patient is often prone or semi-prone.
Right, bad for the airway.
Two, they're often septic from cholangitis and effectively unfasted because of ileus. And three, access. Once they are prone and draped, your airway access is terrible. If they obstruct or arrest while prone, resuscitation is an absolute nightmare.
So what's the recommendation for a complex ERCP?
The recommendation is often to choose general anesthesia with endotracheal intubation. Secure the airway properly, then flip them over and let the surgeon work without you having to worry about an unprotected airway.
And bronchoscopy.
Even more direct competition for the airway, they're literally putting a scope through the vocal cords. We often use Tavia here because any anesthetic gas just leaks out around the scope.
Right.
And for rigid bronchoscopy, they might use something called jet ventilation, high-pressure oxygen injection. The big risk there is barotrauma, like a pneumothorax, and you also can't measure end-tidal CO2 accurately.
Okay, last one. The Cath lab.
The Cath lab. The main hazard for us is radiation. You must wear a heavy lead apron. It's hot, it's tiring, and it puts a strain on your back.
I've heard the table moves a lot, too.
All the time. The table moves. The C-arm rotates. I have personally seen IV lines and breathing circuits get caught in the C-arm and ripped clean out. You need long extensions and constant vigilance.
And the contrast media.
Contrast media.
Yeah.
Two big risks: anaphylaxis and contrast-induced nephropathy, or CIN. Anaphylaxis in the cath lab is high stakes because the patient is draped head to toe. You might not see a rash, you just see profound, unexplained hypotension. You have to know where the adrenaline is and be ready to use it.
Okay, that covers the specific locations. Let's move to Part G, complications and safety. What actually goes wrong in NORA? What are the stats?
According to the ASA Closed Claims Project, the profile of complications in NORA is very different from the OR.
How so?
In the OR, we tend to worry more about cardiac events or awareness. In NORA, the #1 cause of malpractice claims and patient injury is respiratory events.
Not cardiac, respiratory.
Yes. Specifically, inadequate oxygenation and ventilation. The mechanism is almost always the same. Oversedation plus no capnography in a dark room with distant health.
And the patient just slowly drifts off.
The patient stops breathing, nobody notices until the pulse oximeter alarm goes off 5 minutes later, and by then they've already suffered a hypoxic brain injury. It is an entirely preventable catastrophe.
And aspiration.
Aspiration is a very high risk, especially in GI procedures where the stomach is being insufflated with air, or in emergency cases where fasting guidelines were ignored.
And cardiovascular instability.
Of course. Hypotension in volume-depleted elderly patients is common, and arrhythmias are a known risk in the EP lab. But respiratory events are the big killer in NORA.
So safety guidelines, we've mentioned the rescue concept. What else is key?
Checklists. The WHO Safe Surgery Checklist needs to be adapted for NORA environments. You still need a sign-in, a timeout, and a sign-out. It forces communication.
And post-procedure care is just as important.
Absolutely. You can't just finish the procedure and wheel them into the hallway to wake up.
Which brings us to Part H, post-procedure care.
The recovery standards must match the main post-anesthesia care unit, or PPU. You need a dedicated recovery area with oxygen, suction, and full monitoring capabilities.
And for discharge, especially for ambulatory cases, we use a scoring system, right?
Yes, the Aldred score is the classic one. It scores 5 parameters on a 0 to 2 scale.
What are they?
Activity. Can they move their limbs? Respiration. Can they breathe deep and cough? Circulation. Is their blood pressure within 20% of baseline? Consciousness. Are they fully awake? And oxygen saturation. Is it above 92% on room air?
And you need a certain score to be discharged.
Usually you need a score of 9 or 10 out of 10 to be discharged from phase 1 recovery.
And what about the escort rule? That's a big medical legal point.
It's huge. The responsible adult escort. You cannot, under any circumstances, discharge a sedated patient to a taxi or an Uber. They need a responsible person to take them home and stay with them. If they leave alone and have a complication at home, you are liable.
Okay, we are in the home stretch now. Part 1, exam integration. How do I bring all of this together in a really structured, high-scoring answer? Let's say I have to draw a comparison table, or versus a NORA.
Examiners love tables. They're clear and concise. So for the OR, you'd write, environment is sterile, spacious, with familiar, trained help. Equipment is standardized and dedicated. And control. The anesthetist controls the room.
Okay, and for NORA?
For NORA, environment is often contaminated, it's cramped with untrained help. Equipment is often scavenged, older machines. and control. The proceduralist often dictates the pace and the room setup.
That's a great contrast. What about another table, sedation versus GA and Order R?
Good one. For sedation, pros are faster recovery, usually less hemodynamic swing. Cons are a big one. Unprotected airway, which means aspiration risk, and also potential for motion artifact if the patient moves.
And for GA?
For GA, pros are a secure airway with an ETT, absolute immobility, and total control of ventilation. Cons are a longer turnover time, it needs more equipment, and you have to manage the hemodynamic effects of induction drugs.
Perfect. Finally, let's rehearse the Viva traps. These are the questions designed to make you fail. Trap number 1. It's just a little sedation. The examiner says, "Doctor, can't we just give a little propofol in this room with no suction?"
Your answer needs to be firm and professional. Sir, patient safety is non-negotiable. I will not proceed until I have confirmed that suction, oxygen, and emergency drugs are present and working as per the SOPM checklist. The risk of airway compromise in a remote location is significant. You have to show backbone.
Okay. Trap 2, monitoring. The examiner asks, is the pulse oximeter enough for a healthy patient?
No, sir. Pulse oximetry is a lag indicator of oxygenation. Capnography is mandatory as it provides a real-time measure of ventilation and is our earliest warning for apnea, especially in a sedated patient with a shared airway.
Love it. Trap 3, the MRI code blue. The examiner says the patient arrested in the magnet, run in with the defibrillator.
Absolutely not, sir. My first action will be to call for help and immediately undock the table to evacuate the patient to the relative safety of Zone 3. Only then, outside the magnetic field, will we commence resuscitation with standard ferromagnetic equipment.
Evacuate to Zone 3. That's the key phrase. Okay, last thing. Summarize this all for me in a 10-mark answer structure. How do I write it?
Easy. 1. Define NORA and cite the increasing volume and risk. Maybe you mentioned Miller's. 2. List the common locations, grouped by specialty.
Rad, GI, cardio.
Exactly. 3. Discuss the challenges. Use those phrases. Hostile environment and the sick patient paradox. 4. Preparation. Write out SOPME vertically and explain each letter.
Got it.
5. Monitoring. You must emphasize the critical importance of capnography. 6. Give 1 or 2 procedure-specific points. Mention the magnet in MRI and the prone position shared airway in endoscopy.
And the conclusion.
And 7. Your conclusion. In summary, the standard of care in NORA must equal that of the main operating room. Meticulous preparation, vigilant monitoring, and adherence to safety protocols are paramount, as the anesthetist acts as the guardian of patient safety in a location not inherently designed for it.
Fantastic. I feel so much better about this topic now. It's really gone from being a vague, soft topic to a structured, high-yield essay right here in my head.
That is the goal. If you treat NORA with the respect it deserves, you'll pass the exam, and more importantly, you will keep your patients safe when you're working down in the basement.
To everyone listening, visualize that dark room. Visualize your SOPM checklist. You have the knowledge. Now you just need to apply the structure. Good luck with the exams.
Good luck, and stay safe out there.
Thanks for listening to The Deep Dive. We'll see you next time.